would ask you to mute we would ask you to mute your audio, and then if we have a few minutes at the end, if there's additional questions, we can certainly go through. Welcome to Ask the Expert.
Were you able to get in? Oh, let me look. I
Oh,
didn't see if you sent it to me.
Maybe,
Oh, no,
folks.
could you mute?
Yeah, I
Could you
don't see
mute?
it on any of the And Meredith is
Could you mute, please? We're asking everyone to mute till at the end. Thank you. Welcome. And again, Ask the Expert is a session that we do every third Thursday of the month. And we hope that you can join us and spread the word about it. It's for everyone to come together. And based on some of the questions that you've sent in, we have formulated our speakers' answers. So why don't we go to the next page?
One second, like Jane, I'm having issues with my share right now. Hold on one second.
Oh, okay.
Okay. I think I have it.
Okay, good to go?
I think so. Thank you.
Okay. All right. Well, our speaker today is Dr. Carrie Nieman. She's an associate professor here of otolaryngectomy and head and neck surgery at Johns Hopkins School of Medicine. And this is a topic that many have asked about, and that's the impact of hearing loss on cognition. So we enjoy the feedback and information you give and come up with these questions. So we're going to go ahead and begin. Thanks, Dr. Nieman, for joining us today.
Thank you, Jane, and thank you all for being here.
Okay, our first question, we'll wait for Wendy to, is can you describe age-related changes in hearing? What happens as we age? I'm getting up there. I want to know.
Yeah, good, great. Thanks, good question. If you could do next slide. So I think we can back up and just speak a little bit in terms of what is hearing loss. And so next slide. In terms of kind of the big picture of what is hearing, it is a series of encoding and decoding. So, we have sound waves that enter our ear and specifically enter our inner ear, our cochlea. And next slide, our cochlea then our inner ear has to encode, process that sound. And then next slide goes ahead and sends those signals to the brain, where the brain then needs to decode that signal or that message. And when that process all goes smoothly in terms of each step of the way, next slide, we are then able to kind of understand what people are, telling us, what we're hearing in our surroundings. And that whole process of encoding and decoding messages can change. And that process that is what then translates to hearing loss. And so, yep, you can do next slide. Thanks, Lindsay. There are a number of different things that we know for sure affects hearing. And we certainly know that genetics has a big impact. I think, each year we identify more and more genes that have a role in that process, whether we're thinking about children who are born deaf, or even in terms of genes that may have an influence on our hearing as we age. Noise exposure is another big driver or risk factor for hearing loss. And so we often think about occupational noise exposure from, service in the military. And then, we think about recreational noise exposure, whether it's, loud concerts or kind of regular exposure to music or things like that. And what matters most for noise exposure is how long a time are you exposed and how kind of intense or loud that sound is. That's what matters most, kind of over time, what we see at a population level. But by far and away, the biggest thing that influences that process of hearing, from that getting those sound waves in, processing them and sending them onto the brain, and then, processing them again, by far and away, aging is the biggest risk factor when it comes to changes in hearing. And so what then happens when we have any of these influences, and we can never really tell for sure what combination of factors, if you come and you get your hearing tested and somebody says, oh, you looks like you have hearing loss, we really don't, on an individual basis, don't have the ability to kind of tease out, is it genetics? Is it noise exposure? Is it aging? Or some combination of all these factors, likely some combination of all those factors. So we don't always have the ability to say precisely, for somebody, patient who's sitting in front of me. But what we do know in terms of what happens then, and I think, the lived experiences of people who are experiencing some changes in their hearing, next slide, is that this process then of sound waves entering the ear, the inner ear trying to encode that signal, it breaks down. So it's not able to encode those signals or send that signal as clearly as possible to the brain. And so then, next slide, the brain is left trying to kind of interpret this bit of a garbled signal. And then, next slide, we're not always sure exactly what people said. So in terms of, can you describe some of the changes in hearing? I think some of the ways that hearing loss kind of first presents itself is a feeling like I can hear you, but I can't always understand you, or a feeling like people are mumbling. So oftentimes it's hard to recognize these changes because they're really slow, they're very, gradual. Vast majority of age-related hearing loss is in the mild to moderate range. So it's not something, that like hits us over the head and is a sudden change, but is something that creeps up on us and is we're not always aware of it. And so, often be like, oh, everybody around me is mumbling, they're so hard to understand, or when there's some background noise, I struggle then. And so oftentimes it's hard to recognize these subtle changes that are happening. So I think those are some of the ways, I think the most common ways that people may start to recognize, or your loved ones may start to recognize some changes, like the TV volume being louder. And a lot of that is all happening at a like a cellular molecular level in the inner ear, in terms of those age-related changes.
Next slide.
Yeah, I was gonna say, Jane, any other follow-up questions to that, or?
Does anyone have any questions or clarification? Are we good? Okay. How about if we ask you, so what are risk factors that impact hearing? I think you hit upon
Yeah.
some of those.
Yeah, exactly. Yep. Yeah, exactly. So, so next slide. So like we talked about, right, for most of hearing loss. So when we look at a public health level, I think we can think about, we may know somebody who was born deaf, or may know somebody who's had hearing loss as a younger person or as a child. But if we look at a population level, at a public health, from a public health perspective, the biggest number of individuals who have hearing loss is age-related hearing loss. And so when we look at whether the US or other populations, other countries, we see, when we look at everybody who's 70 years and older, 2/3 of individuals who are 70 years or older have a clinically significant hearing loss. And we know that kind of numbers roughly double with each decade of life. And so we'll talk a little bit more about that in a second. So this is just emphasizing, for sure, every day, day to day things that you can do to try to help your hearing is thinking about, wearing hearing protection. But some of, that may not fully determine, even if you're really good about using hearing protection, whether it's, using the vacuum cleaner, using power tools, mowing your lawn, those are all things that should prompt you to think about wearing hearing protection. Even if you do that every single day and are really good about it, you still may have changes just because of those genetic components, but again, by far and away, the age-related changes that almost all of us will experience at some point in time. Yes, so thank you.
So does hearing loss matter as we age?
Yeah. So this is something that I think, at least in I think in a lot of kind of medical clinical settings, this has really shifted in the past, I'd say 10, 15, 20 years, in terms of how we think about age-related hearing loss. A lot of work has been done in this space in terms of understanding, does it matter? I think for many, many years, we've thought about it. It's just this kind of normal part of the aging process that doesn't really have a lot of influence in terms of how we age. But that certainly changed. And so next slide. And I think one of the reason, and this kind of is a graph that or figure that shows just how common hearing loss is. And so our understanding, yes, we've always known that it's common, but being able to really put numbers on it is something that helps us think through some of this. And so, like I was saying, when we look in the United States and everybody who's, 70 years or older, 2/3 have that clinically significant hearing loss. And when we look at everybody who's 80 years or older, over 80% have a clinically significant hearing loss. And again, it's mild to moderate hearing loss. It may not be something that you notice or that your family notice, because you do pretty well in a one-on-one setting if it's quiet. But if there's background noise, social gathering, family gatherings, and you're struggling or feeling like people are mumbling, that may be age-related hearing loss. And so next slide. And so hearing loss is really, really common. And like I was saying, in terms of, if you can do next slide, Wendy, thanks.
Sorry, it was Jane.
Yep. Thank you. In terms of, it's really common, and a lot of work has been done in terms of thinking about hearing loss. When we've looked at large kind of population studies where we have some information about somebody's hearing status, not just kind of if they feel like they have hearing loss or not, but an objective measure of their hearing. What we've seen, like study after a study, whether it's in the US or other places, that hearing loss, kind of an objective measure of hearing loss, is independently associated with a bunch of negative outcomes. So when we try to control for lots of other things that may also be influencing these outcomes, we see hearing loss have a connection there, whether we're talking about accelerated cognitive decline, memory changes, dementia, falls, things like depression, social isolation, all of these things that we know matter as we age. We see a connection between hearing loss and a lot of these things, which is, something that is relatively new over these past, few decades. I think we've kind of seen it, in our loved ones, or experience it in our own life, but being able to kind of point to some data that captures that is something that we haven't had until these past, 1 to 2 decades now.
Sorry, I muted myself. How does hearing loss impact cognition?
Yeah. So thank you for the question. This is an area that, just like you said, I think has received the most attention over the past years. And it's complicated. It is definitely not a one-to-one. You have hearing loss and you get dementia. So if you take nothing away, from this conversation, to just know that it's an area still of very active investigation. We have some signals, but we don't have clear answers. So if nothing else, to know that's that. But we'll talk through and walk through some of what we do know, or we're we're starting to understand in this space. So just like I was talking about those kind of large population studies, what we saw and a lot of this work has been based at Johns Hopkins, led in part by our team, my colleagues at the Cochlear Center for Hearing and Public Health, which is Frank Lin and Jennifer Deal and a number of other leaders in this space, is we would see when we look and use an objective measure of hearing, so not just, again, if they feel like they have hearing loss or not, and we look and see, is that connected to things like accelerated cognitive decline or risk for dementia, while controlling for lots of other things that we know can contribute to accelerated cognitive decline or dementia. They found pretty consistently that even a mild amount of hearing loss, so maybe hearing loss you may not even know or recognize, was associated with the 2 times increased risk of dementia. A moderate amount of hearing loss was associated with a 3 times increased risk of dementia. And a severe hearing loss was associated with a 5 times increased risk of dementia. What is really important, again, these are population level studies. These are not what you can't take these numbers and say, I have mild hearing loss. That must mean I have a 2 times it. These numbers cannot be used for an individual level, but this is what we see, at a larger study level. And so this diagram, some people may be familiar with it. The Lancet Commission is an independent body that often gathers experts to help think through kind of the latest evidence around important questions. And so they put out in 2017 one of the first reports on dementia that looked at all of the potential risk factors that we know in terms of things that may contribute to risk of dementia. And that 2017 report, that was the first time that we had enough information, high quality information about the potential association or linkage between hearing loss and dementia, that hearing loss was then included in that study of looking at all the potential risk factors that may contribute to dementia. And so when they looked over the life course of all these different factors, what they found is that hearing loss was one of the largest potentially modifiable risk factors, again, at a population level. And so, again, not at an individual level. And so what that really is a reflection of is just how common hearing loss is and how strong that association seems to be when we look at these population studies. So that's all of, kind of what we've seen, so far. But what is, the big question in the room is, can we do something about hearing loss in midlife or later life and actually see changes in terms of cognition? And so we'll get to that in a moment, but let's do next slide. So we see this potential association. And so, how are these potentially associated? We have a number of different theories. We don't know for sure, and we still don't know for sure kind of how these things may be connected. And so the different theories are, one, that changes in, hearing, because we've got this garbled, degraded signal that our ears trying to send along to our brain, but our brain then has to take extra energy or cognitive load to try to process that signal. And so is that then taking cognitive resources away from other kinds of processes that need to be happening? Is that the way that hearing changes may connect to cognitive changes? The second kind of potential theory are, the process of hearing loss and the changes that happen, are those translating to actual structural functional changes in the brain that are then also translating to differences in how we process and how we think? And then the third potential way that these may be connected is that we know that hearing loss, right? We may withdraw, we may not connect, we may not engage as many of the activities that we normally may do when we have some changes because it's just so frustrating and challenging. And so we know social isolation, regardless of the cause, social isolation alone is a risk factor for memory changes. And so is that the way in which, changes in hearing are connecting to memory changes? And the fourth, is that there's just some kind of common process or pathway that connects both hearing loss and cognition. that don't fall into those. So those are ways in which we think these connections may be there, but again, we don't know for sure.
So the question is, if you get a hearing aid, if you've been identified as having a hearing loss and get a hearing aid, does that reverse the changes or slow
Yeah.
down? What
Yeah.
happens?
Yeah, yeah. So this is obviously the a big question. And so we can do next slide. So what we're talking about here is, can we do something about hearing loss and then change something in terms of downstream risk for dementia? So next slide. And so back to this, here again, can we do something here? Can we make the sound clear by using hearing aids? Can we, increase, the stimulation of different parts of the brain by getting a clearer signal to the brain? Can we increase, social engagement or connection with people and see changes then in cognition? And so next slide. The ACHIEVE trial was the first ever randomized controlled trial to try to help us answer this question. A randomized controlled trial is one of the standard ways, really kind of the highest standard way that we try to help answer these types of scientific questions. And so in a randomized trial, we have a question and we have, we recruit a population, and randomly half will get the intervention and the other half do not get the intervention, and we follow them and see then at the end of that set amount of time what changes can we see in the group that got the intervention and then the group that did not get the intervention. I will also say that no single randomized controlled trial is ever going to, definitively answer something. So no matter what trial, we always take it with a grain of salt. But the ACHIEVE trial was the first trial that was actually looking at whether or not, if we give individuals with hearing loss but no memory changes hearing aids, do we see changes in cognition? And so, like I was mentioning, Frank Lin, Joe Koresh, Jennifer Deal, Nick Reed, a number of my colleagues, and many others conducted the ACHIEVE trial. And you can see the dates there from 2017 to 2023. And so the results of the trial came out in July 2023, but I'm going to talk a little bit about the background. And so you can see here, individuals, they got gold standard. They got hearing aids, fit by an audiologist, as many visits to audiologists as they needed to make sure they were up and running with all of the best technology. And then individuals who were randomized who didn't get that then got just health education. So they saw individuals the same number of times as an audiologist. They just didn't get, hearing aids, but they, how can you improve, healthy lifestyle? And so the main outcome was to see, are there changes in cognition 3 years after receiving this hearing aid or this kind of health education control? And then they looked at a whole bunch of other outcomes in terms of things like physical activity and mobility, falls, doing MRIs, lots of other things that they also looked at. And so next slide. This, they recruited from 4 sites across the country during this time, almost 1,000 individuals. And you can see the different sites around the country. It's based at Hopkins, North Carolina, Mississippi, Minnesota. And individuals needed to be around 70 to 84 years of age. They had to have clinically significant hearing loss, but normal cognition based on a pretty large, robust kind of neuropsychiatric evaluation. So it wasn't just a single test, but a pretty extensive evaluation. So next slide. So the main thing here about this slide, I know it kind of shows some of the same information as before, is in the dark blue boxes. So I said almost 1,000 individuals were part of this study. The study recruited from 2 different sources, and this is really important as we try to think through and understand the results. So the largest number of participants, around 700 of the participants, came from those 4 sites, but they were newly recruited, ads, message flyers saying, hey, if you think you have hearing loss, like, do you want to be part of a hearing study, that we're looking about, memory changes? And so recruiting, individuals who are pretty motivated to be part of a study. And so that represents, 700 or so of those individuals. A smaller number, around 238 individuals came from an existing study. It's an existing observational study, something called the ERIC cohort. And though that's in part the reason why they worked at those 4 different sites in the country, because those are the 4 sites of this ERIC study. The ERIC study was originally a study that was just looking at recruited healthy adults, midlife, so they were just following these individuals. And so these individuals haven't necessarily received any intervention, but they were randomly selected from community populations as adults and have been followed and been part of this study for 30 years now. So we know a lot of information about those individuals. And again, they're randomly selected. They weren't, seeking out hearing aids, but they were randomly selected when they were middle age and then have been now followed. And so that group, is different than the group of individuals who are like, oh, yeah, I have hearing loss, sign me up for a study. So next slide. So I know this is a whole lot of stuff here, and we don't need to focus too much here. But the results came out in July of 2023 of this study. So again, looking at hearing aids for people with hearing loss, no memory changes, 3 years after receiving hearing aids, what do we see in terms of cognitive decline? And so in the overall study, when we looked at those almost 1,000 individuals, we did not see a change in cognition 3 years out from receiving the hearing aids. But what we did see, so remember we had those 700, healthy volunteers who had hearing loss but no memory changes, and then those individuals who had been in that longer ongoing study. What we saw is that smaller group, those individuals who've been in that longer ongoing study, we did see a change in cognition 3 years out after receiving the hearing aids. And some of what we think is going on is when you look at those healthy volunteers who signed up for the study and you looked at that group's changes in cognition over 3 years, there really wasn't much change in memory for those individuals. So even though they may be benefiting from their hearing aids, when there's not a lot of memory changes going on, we're not going to be able to see much difference between those who received hearing aids and those who did not. But in that group who had way back when been randomly selected from the community, that group, they were older, they had more risk factors for cognitive decline while they had started the study without any memory changes. In that group, there was more change in cognition overall in that group over 3 years. And then we could see, because there was some change, we could then see some differentiation of those who had received the hearing aids, a 48% reduction in cognitive decline 3 years out following. So how we interpret and take this information is that it looks like in some individuals who may be at increased risk for changes in memory, that doing something about hearing loss may help in terms of slowing cognitive decline. So I know there was a whole lot, so I'm happy to pause here. Any questions? Or Jane, any comments before we move on?
So there is a question that
Mhm.
is the presence of, whoops, it went off my screen. Hold on.
Yep.
Is the presence of tinnitus in midlife indicative of loss of cognitive function in later years, or do hearing aids reduce tinnitus symptoms and sequela?
Yeah, so good question. What we know and understand about tinnitus or tinnitus, either pronunciation is correct, is that we really think about tinnitus as a symptom or a product of underlying hearing loss. that's not 100%, but generally we think of it, there's some changes that have happened in the inner ear, and that the inner ear is then no longer sending the same signal to the brain, and the brain then starts making different sounds. So tinnitus or tinnitus, while it seems like it's coming from the ear, is actually a brain phenomenon. So I would say the underlying, potential for hearing loss, may be a risk factor for changes in cognition, but tinnitus or tinnitus itself has not necessarily been linked to memory changes. And then that second part of the question in terms of hearing aids, not all, but for many people, when you kind of give that signal back to the ear, back to the brain, that sound often, again, not for everybody and not always, can be more in the background, when you're using hearing aids. The other thing that the audiologist can do is sometimes put noise maskers or things like that into the hearing aids. So it gives you the boost that you need, but then also can help with some white noise or things like that if there's still some tinnitus. But tinnitus is a challenging thing, but we don't know and we don't have evidence to show that tinnitus or tinnitus itself is a risk factor for memory changes.
So my question is,
Mhm.
are we, as primary care practitioners, are we to include hearing assessment in our vital signs maybe? So that we catch things earlier than later?
So yeah, so this is a it seems like it'd be a straightforward question, and I want to say yes.
Sure.
But if we're practicing evidence-based medicine and guidelines, we we don't have evidence for that, unfortunately. So, it's been a big question of whether or not do we include hearing screening in just routine, let's say for somebody who doesn't have any concerns, hasn't noticed any changes, do we screen for hearing? And what even just a few years ago, when the USPTF looked at that question, there wasn't enough evidence to say either way. And so, and I don't know, one of the things that has been challenging the space of hearing is that, we haven't had large, robust, strong randomized controlled trials and studies to help answer these really fundamental and basic questions. So trials like the Achieve trial, even though it's a little bit of a complicated and not clear answer, but trials like this and many others that are trying to help us understand, does hearing loss matter? Because, if we understand that hearing loss matters, then yes, like we should start to screen for hearing. But we don't have the evidence yet, unfortunately, to say, if we screen for hearing loss and pick hearing loss up at 50, at 60, at 70, and intervene, does that change things? So we're just starting, unfortunately, to start to have some of that. Me as if I wasn't, had my evidence-based hat on and say this is what we know in terms of, I would say, of course, everybody, should be thinking about hearing. We know it makes a big difference in terms of just the care that we can provide. And so clinical practice guidelines, I was involved in the American Academy of Otolaryngology's latest clinical practice guidelines for age-related hearing loss. And we recommend that, but it's not obviously as strong a recommendation as the U.S. Preventative Task Force recommendation, says, no evidence to support hearing screening right now. That being said, if somebody is noticing changes in hearing, so they're having some questions or concerns, or loved ones are having some questions, you should definitely get your hearing evaluated.
Yeah, and I think that's a good point too to make, that if there are changes, or especially sudden changes, that
Oh,
people need to
100%.
remember to visit their primary care provider and let them assess to see if they need to be referred.
Yeah.
Don't put that off.
100%, 100%. Yeah. Sudden hearing loss it's a very rare thing, but it's very specific, and there's things we can do and intervene, but it's all based on how quickly you're seen and get treatment. But even if it's not sudden, if you're having questions or concerns, there's things that we can do, and there's more and more options, and we think, the more and more evidence that supports, doing something about your hearing may have, implications in terms of how well we age.
Thank you. So, what is the best way to have your hearing evaluated? What should we do if we think we're having
Yeah.
difficulty with hearing?
Yeah. Yep. So there's a number of different options out there. So next slide. You know, anybody in the kind of hearing care space. So there's audiologists who are clinical graduate, level degree. They specialize in hearing assessments, hearing aids, things like that. There's also hearing aid dispensers or hearing instruments. A specialist, they have an associate's level degree. They can do some basic hearing evaluation. And then ENTs or otolaryngologists like myself also are able to do that, but often also work in partnership with audiologists. So that would be the MD in terms of the hearing care team. So if you're having, questions or concerns, you can always raise them to your primary care provider, or, think about getting a formal hearing test. And then, places like Costco or others, they also offer, hearing evaluation. Costco, follows best practices. And so if you're there and you are thinking about, you can always get your hearing screened or evaluated in that setting as well. And if there's any question or concerns and you would want, something more formal or robust, seeing an audiologist or an ENT, you can't go wrong. If you have just questions, and you're maybe not quite at the point of wanting to go see somebody, there are more and more options in terms of smartphone-based options. So if you have an iPhone, and if you've been playing around with the health app on that, there is a basic audiometric evaluation. It's just a screener, so it's not definitive, but you can do that if you have an iPhone. And then an app that our team recently developed at Johns Hopkins is free. It's available on Androids. It's available on iPhones. It's called Hearing Number, and there's the website there. You can put Hearing Number in, and you can get that, download that again free. It's available in multiple languages. It gives you a rough idea of your hearing status, if that's something of interest, just to kind of know where you may be.
Oh, thank you. And so the question is, how do we manage age-related hearing loss? I think we've answered a little of this as we've gone through, but
Yeah.
are there
Yeah.
any other points?
Yeah. I'll call attention to a couple different resources and things just to keep in mind. So next slide. One thing that we often focus on and think about hearing aids, but one thing that goes hand in hand with hearing aids or devices is communication strategies. So even if you're not using a device, or not ready to use a device, there's some really basic things that can make a big difference, for you and your loved ones, or for thinking about in your clinical practice. So basic things like make sure you get face to face. You try not to scream across the house or scream across the room, turn down background noise. We get a lot of information from reading lips and gestures, seeing emotions. And I think that was clear for many, many people in terms of with masking, with COVID, just how much we rely on all of those signals. Other things that fall into communication strategies beyond, get face to face, turn down background noise, is things like trying to minimize how much you say what or huh, but trying to be specific about what you heard and then didn't hear. Are just some of the examples of kind of the things that all of us can be doing in terms of day to day to try to help and optimize communication. Next slide. In terms of hearings, there's also cochlear implants. So for individuals who have more severe hearing loss, who are no longer benefiting from hearing aids, which is on a population level, a very small number of individuals. Cochlear implants can have a really big role and impact for those individuals. And something that is really important to know is that, a range of individuals, it's not just babies who are born deaf who can benefit from cochlear implants, but older adults. We never use age as a cutoff for who's able to benefit from cochlear implants, if that's the right decision for them. It's something that is really underutilized. So small number of people, but it's underutilized in terms of there's a lot of potential benefit for people who are really struggling to stay connected to the hearing world. So just wanted to put out that. And then a couple next slides are just to point out there's many, many devices out there in terms of whether you go to an audiologist, hearing aid dispenser, an ENT, you would get prescription hearing aids often through them, but there's a lot of other over-the-counter devices and otherwise. Here's just a couple. By no means, these are just some that I've used in my research that are high quality that we've tested, independently. And I don't know if the price is cut off a little bit, but they range from like 250 to 450 for a single device, so not necessarily thousands. There's a new category, next slide, of over-the-counter hearing aids that exist. Some examples here, the prices may be a little bit higher now in terms of Jabra Enhance, Bose Lexi, high quality devices, but it's still quite expensive. But you can just get yourself and get up and running with them. And the next slide, beyond just these devices, there's some really large, simple, easy to use, very affordable devices out there. So for people, if they've had a stroke, have bad arthritis, have some memory changes, can be really, really helpful in terms of whether it's just doctor visits, for meal times. Pocket Talker and the Super Ear are great options and much more affordable. Even if it's, I don't want to take my hearing aids to the hospital because they're going to get lost. These can be really handy to have around. Next slide. The Hearing Loss Association of America has a number of different resources. This is a nonprofit that focuses on individuals with hearing loss and a range of hearing loss. They have information about OTC devices and a lot of other things. Hearing Tracker is an independent website that also tries to help navigate the many different types of devices that are out there. So just a couple things to keep in mind. I know I'm looking at the time here, and I know there's a couple questions there, but yeah, I think we can. I don't know if Jane, if you want to maybe stop here.
Well,
and
I feel like, we've kind of addressed
Yep.
some of this thing, I
Yes.
think, in
Yeah.
regards to that.
Yep. Yep.
I think there's just one other question. Someone has a question in regards to their family member has
Mhm.
dementia, and
Yeah.
the hearing test is sometimes difficult. Is there
Yeah. So it's a
an
good
easier way, maybe?
Yeah, so good question. I will say, just from our work, we work very closely with the memory clinic at Johns Hopkins, and I will say, many individuals are able to go through even just a hearing screening with some prompting. But if that's too much of a struggle, I will say, audiologists are very much trained in terms of their clinical practice. Is evaluating hearing, in newborns and children, to older adults, to individuals with dementia. So they have a number of tools and approaches that they're able to use. So if you haven't, seen an audiologist, and there's some concerns, it's worth at least trying. If you have seen an audiologist and it didn't, move forward or didn't go as well as you would want, you know, to some degree, it's, knowing obviously and having an objective measure is helpful. But if there's concerns about hearing and, there's nothing that I think, stops you from trying some of those larger devices like a Pocket Talker or Super Ear, in terms of if they're just not able to clear, and see, does kind of putting on that little bit of extra boost or amplification help? Or is it just, too confusing? Certainly it is hard sometimes to separate out, where memory changes are versus, is it just, not hearing? And so it is a big question, but an audiologist should be able to help go through that. But yeah.
The others are just comments in the
mhm.
comment section that people
Mhm,
can read.
mhm.
I think noting a farmer who has worked with machinery, the farmers need to be educated
Yeah,
about their equipment.
for
Certainly, I
sure.
think everyone does that uses any kind of loud equipment.
Yeah, for sure. For sure.
And some
For sure.
people have noted that sometimes family members are recommended very expensive hearing aids.
Yes.
Which
And
that
that's,
website will be helpful, I think, for them to
yeah.
look.
And just to over-the-counter hearing aids are relatively new on the market. They're still pretty pricey, but we really hope more and more that market comes down. And if you feel like you're not getting, answers from your audiologist. They may not be very comfortable with over-the-counter hearings, or they may not be appropriate for your loved one, but there's a lot more options out there. There's even glasses that act as hearing aids that are either on the market or about to come out on the market. So it is really opening up, and we're really hoping that there's fewer and fewer barriers to thinking about and trying to get some help and assistance when it comes to hearing, because it is so fundamental, to our everyday lived experience.
Yeah, I can't thank you enough. This has been so informative, as many have noted in the chat as well. Thank you so much for your information and expertise.
Yeah.
If anyone has additional questions, you can certainly email them to Wendy or I, and we can try and have them answered for you. But we appreciate everyone joining us. We look forward to next month, our series only based on your input. We're going to chat with Dr. Weiss about Parkinson's disease and dementia. So join us then. And again, thank you, Dr. Nieman. We appreciate your time and help with all this, with the topic. It's so informative and practical for us working in aging areas, as well as for our caregivers.
And I do want to share that this recorded webinar will be posted on our Maryland Living Well Center of Excellence website, along with the slide deck that Dr. Nieman shared. Thank you again, Dr. Nieman. We really appreciate you joining us. There's also be a page of resources. We do offer evidence-based programs virtually in a statewide capacity. So if you haven't checked that out on our website, please make sure you do. We are offering monthly caregiving and dementia workshops, as well as a series of diabetes workshops that are available currently.
Hey, good afternoon.
Thank you. Appreciate y'all coming.
It's probably